Hello everyone. Today we will discuss on this new molecule that is Dostarlimab, the magic bullet. Let us discuss all the frequently asked questions on this particular molecule. So if you look into the localized rectal cancer, which includes stage 2 and stage 3, the present day standard of care for such disease is a tri-modality therapy, which includes chemotherapy, radiation, and surgery. If we can do all this in a proper sequence, then the 3-year DFS is 77%, which is quite impressive, and also results in rectal preservation. However, such a treatment is associated with substantial long-term sequelae, including peripheral neuropathy, bowel bladder disturbances, and sexual dysfunction. Therefore, there has always been an attempt to avoid surgery in these patients. Among this, we have the organ preservation of rectal adenocarcinoma study. In this, the 3-year disease-free survival is 76%. This is in par with the previously existing trials. And they looked into another important endpoint, that is rectal preservation at 3 years, what we call as the TME-free survival. So the TME-free survival, the total mesorectal excision-free survival, is 41% if you start induction chemo followed by concurrent chemoradiotherapy, and it is 53% if you start with concurrent chemoradiotherapy followed by consolidation chemotherapy. So, well, having said that, even in this study, nearly 50% of the patients required surgery. The total mesorectal excision was required. So, having said that, tri-modality therapy is associated with substantial toxicity. So, if you have an option to omit surgery and to omit all the tri-modality therapy, that would be great, because this will take care of the toxicity part. Then what is this Dostarlimab? Dostarlimab is a humanized monoclonal antibody. It binds to PD-1 receptor. This is not the only PD-1 we have. We also have pembrolizumab and nivolumab available in our country right now. The other two drugs like cemiplimab, toripalimab are also there in this group. So dostarlimab is not a new molecule. It has got previously approved for advanced endometrial cancer who had progressed on platinum. They should have had a deficient MMR or MSI high. And this is based on the phase 1 Garnet study, a single arm study of 104 patients. Here, they reported a response of 42% and a complete response of 12%. Similarly, the drug also got a tissue agnostic approval for MSI high patients in relapsed refractory solid tumors. This was also a single arm study of 106 patients, and they included non-endometrial cancers, and 93% of them were GI cancers. This also showed a response rate of 38% and a complete response of 7.5%. So what I would note in this is the complete response for dostarlimab in an advanced disease is just, one is 12%, another one is 7.5%. So the complete response is not that great in the metastatic setting, even in MSI high tumors. Well, why MSI high tumors are exquisitely immunosensitive? This is the probable reasons. When there is a mismatch repair deficiency, there are a lot of new antigens that are produced. There are a lot of mutations that happen within, which are defective, of course. This results in a lot of new antigens being expressed on the surface of cells. This makes them exquisitely immunosensitive. The dose of Dostarlimab is 500 milligram once in 3 weeks for the first 4 doses, and from 5th dose onwards, it is 1000 milligrams every 6 weekly. Well, what is the study on rectal cancer, which is the point of interest? You've seen all the newspaper headlines everywhere saying that, and a lot of the patients asking that there is a 100% cure for cancer, and it is based mainly on this study. This is a phase 2 study, single arm, stage 2-3 rectal adenocarcinoma. Here they gave Dostarlimab 500 milligram 3 weekly for 9 cycles, that is, it comes to 6 months. If there is complete response at 6 months, then there was an option of not doing the trimodality therapy. If the patient was not in CR, then to proceed with the trimodality therapy. This is the framework of the study. What are the endpoints of the study? The endpoints was sustained CR at 12 months after completion of Dostarlimab. This is in patients who do not undergo the trimodality therapy. Whereas if they undergo the trimodality therapy, in them the endpoint is pathologic complete response. And then the third was overall response rate to Dostarlimab. So the inclusion criteria is they included stage 2, stage 3 adenocarcinomas, and they should have been proven to have MSI high by IHC. So if you look into the demographic data, nearly 56% patients had a T3 disease and 94% patients had a node positive disease. So this sort of reflects the real world scenario. And what are the tests in addition to IHC they did for looking into MSI? They also did a proper NGS, and they confirmed the absence of coexisting mutations like BRAF, which is present in nearly 30% patients. And they confirmed the deficient MMR status. And they also measured the tumor mutation burden in these tumors. And they found a high TMB, and the mean TMB was around 60. So 57% of them had germline deficient MMR status. Even though there was no family history, they did find a germline deficient MMR status in nearly 57% patients, MSH2 being the most common among them. Well, what were the tests for response assessment or for initial examination or response assessment? What all they did for staging? They did a digital rectal examination, endoscopy, and biopsy. Remember, all three was done at baseline, 6 weeks, 3 months, 6 months, and then 4 monthly. This is the frequency. Whereas if you come to the imaging modalities like MRI, PET CT, CCT, chest, abdomen, and pelvis, this was done at baseline, 3 months, 6 months, and then 4 monthly. So out of 16 patients was there in the study. Out of them, 12 completed complete 9 months of Dostarlimab. Among those 12 patients who completed 6 months of therapy, 100% of them had complete response. 12 out of 12 patients had complete response, which is really phenomenal. In these set of patients, we could omit the trimodality therapy. So only 9 doses of Dostarlimab, complete response, no further trimodality therapy. The symptom resolution was quite quick. The PR bleed, pain, and constipation resolved nearly 9 weeks interval. At 12 weeks, 5 patients had an endoscopic CR and 2 patients had a radiologic CR. And then coming on to the histopathology, as the time went on, the tumor cells came down, whereas the CD20 positive nodular lymphocytic aggregates went on going up and they increased to nearly 6 to 10 times at 6 months. So the typical representation, you can see the endoscopic findings, how a grossly proliferative lesion has shown complete resolution at 3 months and 6 months. A rectal MRI also has shown complete resolution at 3 months and 6 months. And a FDG PET also has shown extremely good resolution at 3 months and 6 months. So this is quite phenomenal. Just 9 doses of Dostarlimab, no trimodality therapy, complete response in 12 out of 12 patients. So this is the viable tumor cells. If you look into, you have those arrow mark pointing to viable tumor cells in the rectum. They undergo necrosis soon at 3 months, and then if you follow them up longer, they get replaced by lymphoid follicles, what we call as tertiary lymphoid aggregates, and the tumor just gets reduced to acellular mucin. So if you follow them up, the viable tumor cells reduce, necrosis happens, and it gets replaced by lymphoid follicles with acellular mucin. So, well, why neoadjuvant immunotherapy worked only with Dostarlimab? Why not with other immunotherapy molecules? The key was a prolonged neoadjuvant therapy of up to 6 months. Whereas if you look into other sites, like lung or melanoma or colon, where they have used NeoEP, they have all given a very brief period of neoadjuvant therapy. And even a deficient MMR treatment refractory colorectal cancer, in the early stage, Toripalimab, where a PD-1 blocker, which is a PD-1 blocker, was used for 3 months only. So we have not been able to see a phenomenal response to neoadjuvant immunotherapy. The probable reason is a very brief duration with other molecules, whereas with Dostarlimab, they have used proper 6 months of neoadjuvant immunotherapy, which is unique for this particular study. Well, why only localized rectal cancer tumors respond so well? Why not advanced? If you see the advanced tumors, even the GI cancers, there the response was 40% and the complete response was around 10%. So treatment naive metastatic colorectal cancer, even with deficient MMR, with immunotherapy, only 10 to 11% complete responses. But what is unique with localized or locoregional colorectal cancer is that there are 3 important contributors for this. Number one, the underlying gut microbiome that is there in the lumen. This has a definite immunomodulator effect, and this augments the immune response. Number two, the resident GI lymphoid cells, what we call as the mucosa-associated lymphoid tissue. This is also important because there are already pre-existing cells in the mucosa. And then comes the deficient MMR status in the tumor cells. This makes them to have a lot of new antigens and they become exquisitely immunosensitive. So there are 3 factors. Number one, the lumen has gut microbiome that enhances or augments immune killing. Number 2, in the wall, we have already resistant lymphoid cells. And number 3, the tumor is exquisitely sensitive to immunotherapy. Probably because of this, the localized rectal cancer has shown such a dramatic response. The same cancer, when it metastasizes, there, even though there is dMMR, but you lack the resident lymphoid cells and you lack the gut microbiome. Probably for this lack of these two factors, there is only a complete response of 11%. Whereas if it is confined to the rectum, you have all these three factors playing together, acting synergistically, resulting in 100% complete response in this particular study. Well, coming on to the gut microbiome and immunomodulation, the augmenters of immune response are something like Ruminococcus and Akkermansia. These two species sort of augment the immune response, whereas Fusobacterium nucleatum suppresses immune response. Just to say that the food habits and the ethnicity will decide on the gut microbiome, and this probably also has an influence on the responses to immunotherapy. Very importantly, you attained a complete response at 3 months, 6 months, and even at total 1 year from starting therapy. Sustained CR at 1 year was seen, but does it mean that these responses are durable for 2 years, 3 years, and so on? So whatever evidence we have from metastatic tumors is, if you have a response, the durability of response is nearly 75% at 30 months. Extending on to this sort of immune response, if you look into the evolution, the objective evidence for evolution of immune response, you can see the PDL1 cells, the CD8 plus T cells, and the CD20 positive cells all substantially increase over a period of time. And when all these three increase over a period of time, what we have seen in melanoma is these responses are durable. So a persistently high CD8 and CD20 positive cells are seen in this particular pictorial representation. So you can see how the PDL1 levels in the baseline was not there, and as the time went on, it increased, and then it came down to the baseline and then again increased. So there is definite increase in the CD8 and CD20 cells as we go on. So then coming on to the NIVO-EP study in RCC. So here, in those patients in the intermediate poor risk RCC, if you had attained complete response at 3 months, there was a 86% chance that they remained in complete response even at 42 months. Just to say that if you have a complete response with immunotherapy, it is highly likely that these responses are going to be durable. Well, these are some statements from the authors. They say that we can try and we can evaluate whether such immunotherapy options work for other site localized tumors. Well, to conclude, this study is a small study of only 12 patients, very well planned, excellent follow-up and evaluation periodically. At 6 months of follow-up, all patients remained in complete response. This gives us a hope that in the specific subset of deficient MMR that constitutes around 5 to 10% of the colorectal cancers, may be spared of CTRT and surgery with a better quality of life. Those toxicities like bowel bladder disturbances, sexual dysfunction, neuropathy may be avoided if you can attain a complete response with this drug. So, well, what are the positives and what are the shortcomings of this study? Very important in oncology to see 100% CR is phenomenal. And this subset did not require the tri-modality therapy. Excellent toxicity profile with dostarlimab. As we know, the immunotherapy molecules do have side effects, but not significant, mainly grade 1, 2, and some immune-related side effects. So toxicity profile is excellent. And there is the CR, which is verified by multiple modalities. If you could see endoscopy, biopsy being done every time, MRI, CT, PET-CT, all were done to verify the presence of CR. What are the shortcomings of the study? It's a small study, single arm, only 12 patients, 6 months follow-up, very short. And to put this into practice, you need to call the patient repeatedly. You need to do multiple investigations repeatedly. It's quite tough. You need a patient who has resources and who is willing for such monitoring. And response rate is the only endpoint addressed right now. We do not have the survival data. There can be a difference in the ethnicity and diet, and this may influence the responses to immunotherapy. And very importantly here, the MSI was not just based on IHC, they also verified it well with the NGS and TMB, which may not be practically applicable in all of our patients. So we need to make sure that there are no concomitant mutations before we subject them to immunotherapy in a localized disease. Also, we need to look at other immunotherapy molecules like pembrolizumab and nivolumab. Do they also work similarly in a localized disease? So I think we covered all frequently asked questions on dostarlimab, and I think it would be helpful for you all. Thank you for your patient listening.